So with immunotherapy, it's really understanding a new way of how to stimulate the immune response. So these new approaches with PD-1 antibodies more effectively stimulate the immune response. And it does it in a different way. It essentially is taking the brakes off the immune system. You all know that when an immune response is stimulated, there are counter-regulatory mechanisms that come into place to turn the immune system off. So these work very precisely by taking the brakes off and allowing for a fuller immune response.
Now, you were talking about cancer cells holding up a red flag, and I think that is true of a PD-1 blockade in tumours with the mismatch repair deficiency that Dr. Lee was talking about. What was happening there, and what's the importance of it?
So in that study was looking at certain types of tumors, happens in some types of colon cancer, some types of endometrial cancer, where there are greater number of mutations because there's a normal machine that repairs DNA damage. And so if you are deficient in this repair mechanism, the cancer has a greater number of mutations. And so this means that there could be neoantigens or neoepitopes, new things, new red flags on the surface of a cancer cell that could then be stimulating to the immune system.
What is it about PD-1 blockade that makes this so suitable in this particular situation of these MMR deficiencies?
I don't know that, I wouldn't say that. I would say that these new types of immunotherapy with PD-1 are more potent at stimulating an immune response and work very differently than past immunotherapies. And the importance of the mismatch repair story is, are there groups of patients who are more likely to benefit or not? And so it's an emerging theme that higher mutation load, maybe new antigens being present on the surface would more effectively, that T cells would more effectively recognize those cancers. So I don't think it makes this type of cancer more susceptible, but it tells us that this is a group of cancers that are more likely going to respond to the treatment.
Now, Dr. El-Khoury talked about hepatocellular carcinoma. That's another tumour that we wouldn't have thought of being amenable to immunotherapy. What was happening in that situation?
So in that study, they also looked at PD-1 antibody in patients with advanced liver cancer and really saw some quite striking responses and very durable responses. It's an interesting story emerging that maybe cancers that may be virally mediated are maybe going to be susceptible to these immunotherapies. And again, this may be linked to there's something unique on the surface of the cancer cell that makes it more exposed to the immune system. So this was an activity of a PD-1 antibody in a traditionally very refractory cancer.
What's your view of the clinical applicability of this new immunotherapy in HCC then?
Well, it was very encouraging results. I think we'll need to see a greater number of patients treated, but it looks very promising.
And could I ask you about head and neck cancer, because that's another tumour. Patients who had nowhere else to go are showing a response to immunotherapy now. What again is the trick there?
In that study also, patients with head and neck cancer, the majority of the patients who received the PD-1 antibody had response. Interestingly, in that study, some head and neck cancers are caused by virus HPV, but in this study there was no difference between if the cancer was virally associated or not. So again, we're learning more about which subset of patients are going to benefit, but certainly very encouraging results of looking at PD-1 antibody in head and neck cancer.
Now, in lung cancer, there has already been some demonstration of checkpoint blockade being relevant here. So what did you make of the paper presented by Dr. Pazares?
Well, this is an important study. It was a phase 3 trial comparing PD-1 antibody to traditional chemotherapy and really showed a benefit in overall survival. So previously we knew that both pembrolizumab and nivolumab were active against squamous cell lung cancer. And it's FDA approved for those indications. But in this study showed that in the other type of non-small cell lung cancer, largely adenocarcinoma, the medicine also worked in this situation. We're seeing a growing incidence of adenocarcinoma. This is the kind of lung cancer that the is increasing in number. So to see that the PD-1 antibody approach is useful in adenocarcinoma of the lung is very important. I suspect that this will lead to a change in the label and approval.
What should clinicians be taking home from all of these effects? Because they're quite big signals here, aren't they?
Right. So important to see that these new immunotherapy approaches are going to be used against a much broader array of tumors than we thought. I think it's very important for practicing physicians to recognize that the toxicities are very unique. So these immune adverse events are different. It's diarrhea and colitis. It's endocrinopathies affecting the thyroid and the pituitary. So we traditionally, as medical oncologists, work with infectious disease experts because of the risk of fever and neutropenia. That's not the situation with these new immune therapies. They're very different side effects. It requires a lot of patient education to physicians about how to manage the toxicities.
So do you have any warnings to clinicians?
Yes, understand what the side effects are. Ask your patients and educate them on diarrhea. That's life-threatening potential complication. And so it's recognizing that they're different than traditional side effects of chemotherapy.